Thank you.
Thanks, Ron, for the kind words, and good morning, friends. I'm stepping in for Dr. Sri Ganesh for this talk. He is one of the truly most amazing innovative surgeons I have ever seen in his life, and I had the privilege to be trained by him, and I was with him in my fellowship for 2 years, and then I worked as a consultant with him for the next 8 years. So 10 years being with an innovator, also makes you think in that way. So I'm going to discuss some of the innovations that he made, and I was also part of these innovations. So innovation does not happen overnight. It is a series of events and process that start from identification of the problem, framing a research question, then you have an idea. So you have to have an idea, and then you define the need and understanding of the opportunity. So you need to innovate. Basically, there has to be something that propels you to think in that direction. Is there a need for that? So you have to identify the need first, and then come up with an idea, and then you go on to innovate. So you create a design, you develop a test, and then you implement it in wet labs or otherwise, and then you basically test the proof of concept and risk analysis, and then you get on to the stage of testing the prototypes and clinical trials and filing of the patents, fundings, etc., before it eventually gets commercialized. So it's a long process, and this is unfortunately something we are not able to learn in our post-graduation. So we all know that necessity is the mother of invention, and this is what basically makes the foundation of any innovation that we do. So Dr. Ganesh in 2016, he innovated the capsular fixation IOL, and this idea he got basically when he was swiveling the stand of his bike. So he got this idea when he was basically pivoting it, and then he thought that why not create a lens that has two swivels that can pivot, and this is how he came up with this idea. And this was essentially made to basically tackle the problem of effective lens position. So we all know that in the bag lenses, eventually over time, their effective lens position changes, and also in the case of toric lenses, the lenses can rotate. So this lens basically has two extra haptics, and these haptics can be rotated or pivoted onto the capsular axis, and that fixes the lens, or you can say it locks the lens to the capsulotomy. And you can see in this particular case of toric IOL, the lens position is very well stable, and there is no rotation, and the lens is in its intended position. So this was one of his innovation, and this is another innovation wherein he basically wanted to tackle the problem of toric IOL rotation in small pupils. Now we all know that this is an issue when we implant a toric lens in small pupils. At the end of the surgery, we need to use a second instrument to check the positioning of the lens, and this increases release of the pigments, can lead to post-op IOP, a lot of manipulation, IOP spikes, etc. So basically he was thinking what can be done for this problem, and then he kind of came up with this idea when he was exercising in his gym, and when he kept the barbell on the foam seat, and then we lifted the barbell and he saw that there was a mark. It left an indentation mark, and that's from where he got this idea of making a cystitome marker, a toric IOL marker. So in this marker, there are two windows. So this is an animation. This is a real case. You can see there are two windows through which you can see the marks of the toric IOL, and in the center there is a linear projection. You can stain it also, or without staining also. You just you press it on the IOL, and it just leaves an indentation mark. And then you load the lens and implant the lens in the capsular bag, and you don't have to worry about the pupillary constriction, because you will always be able to see the mark in the center, and hence you can achieve proper positioning of the lens without worrying about the pupil size coming down. This is another innovation, basically Ganesh and Grewal cystitome maker, which was done to tackle the problem of manual cystitomes. So when we make manual cystitomes, sometimes the bend is not accurate, the angle is not accurate. So CCC is one of the most important steps in cataract surgery. So this is essentially a pair of locking pliers in which you place the 26 gauge needle keeping the bevel up, and then you lock the pliers and bend the needle, and you exactly get the desired amount of the angle and the projection. So basically this is based on the standard 25 gauge irrigating cystitome, which is available with Alcon. So when you use this, we did a study basically to see how reproducible it was, and we found that it did help us in creating very reproducible capsulotomies without any complications during the surgery. There were no problems with initiation of the capsulorhexis or extension of the CCC, and it was also very convenient to use. This is another innovation, PCR safety net, wherein I had the idea of making a safety device to prevent PCR, to prevent nucleus drop in PCRs, and I discussed with Dr. Ganesh. So we designed this PCR safety net, which is a temporary rescue device which you can use in the face of PCR with fragments in phaco during the phaco stage. So of course you can't use it when the PCs have already descended. So just it's a foldable hydrophilic device. It has small circles in the center and 4 large circles of 1 millimeter in the periphery. So you fix the device first by making 4 ports and using iris hooks. You really don't need to use 4 iris hooks, you can just use 3, and you can emulsify the fragment, and in the end you can remove the device by simply pulling it out. So the advantage of this innovation is that you can do a proper cortical and vitreous cleanup. You know how much support you have before deciding about your choice of intraocular lens, and you can manage the PCR without extending the wound. So normally we would sometimes extend the wound, the corneal wound, and then remove the piece, so it doesn't induce that much corneal astigmatism. So some of his other innovations were lenticuloschisis, the no dissection technique, Philly, which is another technique wherein you use smile lenticules for correction of hyperopia as well as keratoconus, manual compensation of cyclotorsion in smile, and visco chop technique for soft cataracts in femtolaser assisted cataract surgery. And he has also designed some instruments for smile procedure. So friends, research is not just a frame of mind, it is a process, and anyone can innovate if they have an idea and also the right approach to innovate. Thank you so much.
Thank you very much. Sita, just one quick comment. So I like the toric marking thing,
Yes,
because
sir.
we get quite a lot of small pupils. How long does that indent last for? I mean, do you have to rush and get it aligned?
Yeah.
And is it available yet commercially?
Yeah. So the mark lasts easily up to 2 to 3 minutes.
So enough time to
enough
get
time.
OVD out.
Yeah,
and
yeah,
align
yeah.
it.
In fact, in some cases, it lasts for even longer, because we have seen immediate post-op also. Patient after 10 or 15 minutes after the surgery, you can still see the faint impression.
Right. And is it available yet?
It is, yes, it is available with Epsilon.
Epsilon.
Epsilon Surgicals. Yes.
Okay, thank you very much. Sunpei, any comments?
I think I really admire Sri Ganesh for his great innovations. And I think sometimes, we have an idea, but we don't know how to develop it further.
Correct.
And getting the right industry partner to work with, sometimes, I think in India it's much easier. You have many people who will come forward and help you with an idea. But for us in Singapore, to reach out to someone may not be so easy. So I think Sri has really done wonderful work, and really he's to be congratulated. Thank you very much.
Thank you. I'll definitely convey to him.
Yeah.
Thank you so much.